Motivational Interviewing in HIV Care, the Gifts of Ambivalence and Resistance. This slide set is presented by Debbie Cestaro-Seifer, MSRN, at the University of Florida's Department of Medicine, the North Florida AIDS Education and Training Center. This activity and planners do not have any financial relationships with commercial entities to disclose, and I will not discuss any off-label use or investigational products during the course of this slide set. I have prepared 5 learning objectives for today. They're very active: discussing, describing, listing, identifying, and defining. Quote, unquote, my patients are difficult and in denial. True or false? Patients who are resistant or ambivalent are difficult or in denial. Is that true or false? Patients with low literacy levels are angry, frustrated, and uninformed. True or false? Patients should evaluate their health the same way that their health provider does. True or false? Motivational interviewing is a provider-centered approach to care. True or false? And finally, resistance is informative and expressed verbally and non-verbally. All right, let's see how you did. The first 4 bullets are totally false. And the last one is true. Resistance is informative, and it is expressed verbally and non-verbally if you're watching and listening. And we do that in motivational interviewing. Let's start with what person-centered care is. Person-centered care is providing care that's respectful of and responsive to individual patient preferences, needs, and values, and ensures that patient values guide all clinical decisions. This is a wonderful definition brought to us by the Institute of Medicine in the Crossing Quality Chiasm, a new health system for the 21st century. MI is very person-centered. It is not provider-centered. And on this slide, I get more in depth on what person-centered care is. It's respectful. It honors the individual. It individualizes care. It personalizes care. It most definitely respects patients, and it facilitates the patient experience in what I believe is a very positive way. It's genuine, congruent, transparent, and it involves shared decision-making. One potential outcome of living with HIV is inactivation. Many of our patients show up or don't show up in this condition, this little figure. What promotes an engaging partnership? Well, feeling welcome, feeling comfortable, feeling understood, having mutual goals, and being hopeful. The techniques that motivational interviewing uses in creating patient partnerships are drawing out, encouraging, and motivating. It's guiding patients, guiding individuals in finding out what they can do to have the best health possible. What is motivational interviewing? Motivational interviewing is a collaborative, goal-oriented style of counseling, and it's a way of communicating with particular emphasis on the language of change. MI is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring an individual's personal reasons for a health behavior change. It's a method of counseling. The goal of motivational interviewing is to increase internal motivation to change behavior health. And it definitely does not use confrontational strategies because we know those are ineffective. Motivational interviewing is based on the stages of change model, also known as the trans-theoretical change model. Does motivational interviewing counseling time influence HIV-positive persons' self-efficacy to practice safer sex. This is the name or the title of an article done after a study of a sample size of 490 people living with HIV and AIDS. And this study examined the impact of most motivational interviewing on self-efficacy to practice safer sex. And the conclusion by the authors is that motivational time is a key. It's a key counseling technique to enhancing safer sex self-efficacy among people living with HIV and AIDS. So MI, or motivational interviewing, is a evidence-based practice. And there are many other articles in the literature that you can draw on to find this evidence. So motivational interviewing, on this page you'll see the MI pyramid, I call it. At the foundation is the spirit of motivational interviewing, then come the principles, and then the particular individual strategies. The spirit of motivational interviewing, which is the foundation, is non-judgmental. If you treat people up, they reach up. Motivational interviewing is based on the trans-theoretical stages of change, and those changes or levels or stages of change are pre-contemplation, contemplation, preparation, action, and maintenance. Relapse, although a part of this configuration, is not really a stage of change, but I call it a speed bump on the journey to change. Ambivalence is feeling two ways about something, wanting it, but at the same time not wanting it. It is called the contemplation stage. It's very normal, and it does keep people stuck for a while, but that's a part of making a change in one's life, getting stuck and contemplating change, which is all about ambivalence. Is your patient shopping for change? As providers, we need to ask this question: where is our patient in contemplating change? Are they pre-contemplative, meaning they're not shopping, they're not browsing, and they're not buying? When you are working with a patient who is pre-contemplative, you're not going to spend time in setting up a plan of care or a system of how to take a medication, for example, if they're not shopping or not contemplating even taking the medication. Then on this wheel of change that I've created, you see the other stages of change: contemplation, preparation, action, maintenance, and then of course the relapse, which I call that maintenance. Again, not a stage of change, but an important part of making changes, because relapses and speed bumps do occur. So let's just take an example to see how you're doing with this information so far. Name that stage. My mother doesn't know anything about what I do. I'll take the medicine when I'm ready. I'm not ready yet. It's nobody's business but mine anyways. Is this patient in pre-contemplation, contemplation, preparation, action, maintenance, or relapse? I'm not ready yet. That tells us something. The answer to that question, if I can go backwards, is contemplation. And I want to go back and just say, I'm not ready yet was the key. If we, as a provider, are listening carefully, I'm not ready, but they added the word yet, which means they will be ready at some point. So our job, the conversation, needs to be about when is that time? What needs to happen so that that individual can decide when that time is going to occur. When we listen to individuals for change talk, there are certain words they're going to use that we need to be listening for. Desire, I want to. That demonstrates that they're wanting to do something. They may not be able to do it yet, but they want to. Ability, reason, need, commitment, activation. They may be already taking steps. I'm doing something now. These are all wonderful ways, if you listen for them, you can reflect back to your client, ooh, I just heard you say you want to. That's a powerful statement. Tell me what you mean by that. How do we talk about HIV, managing HIV with patients that come to us? Well, tip 1 would be avoid beginning with the prejudgment that the patient is the problem, that they're resistant, or perhaps they're ambivalent, because just as the title tells us to the slide set, ambivalence and resistance are actually gifts because it lets us work with the patient on what they're prepared and willing and thinking about doing. Tip 2 would be match your strategies and your words to the patient's readiness to change. If we speed ahead and start leading the patient, then we've left them behind and they may become disillusioned and frustrated. If we let them lead and we reflect back that we see their progress, then they're more apt to go and start to make changes or make a plan of care to make particular changes in their health. MI principles that are important. 1, assume the patient is competent and capable. 2, control and responsibility lie within the patient, not in professionals. 3, open-ended questions are the key because they allow the patient to tell the provider and all of the staff what the patient knows, what they're experiencing, and what tools they have to address their situation. And lastly, treating behavior change as a journey. The journey is more important than the destination. The 4 processes of motivational interviewing are engaging the patient, focusing them, evoking change talk, and planning, helping them plan out their recipe for success in making particular health changes. The MI skills that one will use in the MI process, well, the actions would be expressing empathy, understanding what your patient is going through, and letting them know that you understand that. 2, listening. Boy, this one's so important. Asking open-ended questions, finding out what they know, what they feel, what's happening for them. Avoiding argumentation. I think MI is more like a dance. If the patient takes a right turn, then you take a right turn with them. Not meaning that you agree that not taking their medications is okay, for example, but that you step with them side by side and say, it sounds like taking medications is hard for you. Tell me more about that. And learning from resistance. Finding out when a patient does get to their point of, hey, I can't do this, I don't want to do it. Finding out what that's about or what they've done in the past to break through in a situation when they felt powerless or felt internal resistance to doing something that might be in the long run helpful. And finally, as a provider, how do we support the individual's self-efficacy in finding a plan and one that they feel that they can actually master? Self-efficacy is a person's belief that a change is possible for them. The MI approach is that there's no one right way to change a behavior, and MI promotes individuality and creativity in devising a plan or recipe for changing a behavior. People believe they are able who think they are able. That's about self-efficacy. Motivation. Well, in motivational interviewing, we have 2 very important tools, and the 2 most important questions for these tools are, on a scale of 1 to 10, how important is it that you make this change? The importance to you, not the importance to anyone else, but the importance to the individual themselves. And the second question, using the readiness ruler, as you see here pictured on the slide, is how confident is the individual that they will be able to make the change, that they will be successful in following their recipe. The core techniques in using the OARS, which is an acronym for open-ended questions, affirmations, reflections, and summaries. This is the core communication used in motivational interviewing. It is not unique to motivational interviewing, but it is one of the strategies that help motivational interviewing go. It keeps it alive, it keeps the conversation moving, and it allows the provider to acknowledge and to reflect back to the patient what's happening and what is being said by the patient, because oftentimes as individuals we don't hear what we've just said. The ORs are important. You'll use them throughout every session in motivational interviewing. Here are some open-ended questions related to HIV treatment and care. What are some tools you can use to help you remember to take your medications? Tell me what you know about barrier protection and what you use if you use this method of prevention. Here are 10 things MI is not. It's not a way of tricking people to do what you want them to do. It's not psychotherapy. It's not magic. It's not confrontational. It's certainly not argumentative. It's not persuasive. We're not selling anybody anything. And it's not a panacea or panacea. The 10 things MI is, it's a conversation about change. It's respectful, collaborative, it honors autonomy and self-determination. It's very patient-centered, it's goal-oriented, it's empowering, it's cooperative, and it's effective. And finally, it engages patients in care, which is the challenge of any work or anyone that's working in the field of HIV treatment and care. How do we check if we're doing motivational interviewing right? This is a great tool that was put out by Case Western University, and it can be easily obtained online and printed out for you. And you'll see that it's a great tool to put into your pocket or on your clipboard, because after a session, whether it went well or it didn't go well, it's good to check yourself, or maybe even have another professional that's working with you check you and help each other and say, hey, you did this great. You listened a lot, but you could have listened more, and here's examples of what you did when you were listening, and here's some examples of maybe times that you wanted to listen more. And it goes through 11 different pretty much critiquing points. And this is just a great way to get better at motivational interviewing, because motivational interviewing is a skill that has to be learned, and just like anything, any health behavior, it has to be practiced over and over again. And we can always get better. I'm always learning about my ability to use all the tools that are available to motivational interviewing specialists. So I want to summarize what we've learned here in this short didactic. 1, MI is evidence-based. 2, it is patient-centered and goal-oriented, and it is a type of counseling that targets ambivalence and sometimes even resistance. The patient is responsible for the change. So if you are working harder in the conversation than your client, then you are not doing motivational interviewing. And finally, when discussing change, the goal is to elicit change talk and commitment language from the individual with whom you are working. And don't forget to use your ORs. If you'd like to call or reach me by phone, the best way is to send me an email, and I'll be happy to call you or set up a conversation. Would love to talk to you more about motivational interviewing or answer any questions you may have. Thank you so much, and keep up your motivational interviewing.